Good afternoon. Welcome back after the break. We're going to continue with our afternoon surgical lectures. I just realized I didn't give Dr. Giordano a proper introduction. Last time he kind of stepped in to fill in some time. So while we get him going, Dr. Giordano has been in practice in Michigan since completing residency under Dr. Fallett in 2003. So we've both been here our whole time since residency's finished. So he's been a very good contributor to our conference over the years, and I always get a enjoyment out of watching him speak on his presentation. I know he puts a lot of work into this. So with that being said, we'll have him start his presentation.
Thank you, Z. Can you guys hear me okay?
You're good.
Okay. So I'm going to, people don't want to look at my mug, so I'm going to stop my cam and I'm going to start my presentation. And Z, just text me, let me know if everything's kind of coming through together, but let's have a little fun. So welcome from Harrison Township. I wish I could be there with all you guys today. I'm really missing the Henry. But you know, unprecedented times. But let's have a little fun. Who loves John or who doesn't love John Quinones? I really do, and I love this show. What would you do? And it was interesting. I think Dr. Sprunger did a great job. Tad and I have actually operated on the same patient. He's really helped me out. A good friend and colleague. But right at the end there of his lecture, he mentioned two patients that had osteogenesis and went on to degenerate their joints. And I believe one had a failed chylectomy, and both of these people ended up, maybe one got a fusion and another one got converted to the MetHead resurfacing implant. But this is what I'm going to speak on a little bit today. And I wanted to be with you guys in a room. I have a little poll activity here going on. So we're going to give it a try and see if it works. If not, I'll make my way around it. But look at these two bunions right here. This is on the left, there's a 74-year-old active female. And on the right, there's a 23-year-old active female. And just as John Quinones would say, what would you do? I want you to think about this, just looking at the AP. And so this may be a little difficult for people on their phone for the conference, but if you're on a laptop or on a desktop, take out your phone and let's see if this will work. If not, like I said, I'll get around this. But so you're going to text to number 22333 and you're going to text Anthony G 876. And I'll give everybody a second to do that. I'm going to see if this poll will work out. It was going to be a little more enjoyable being in a room with all of you. And then I just wanted to remind everybody, I added that today. Make sure at the bottom right of your screen, at one point you select full screen, because I have some really nice high-res photos. And if you can use the whole screen, it'll show up. But if you've done that, there's that 22333. You're going to see this potentially on your phone if it's working. And what I want you to do is, here's our mid-70s-year-old bunion. And there's no wrong or right answers. You know, nobody's looking over your shoulder because we're not together to see what you're putting. But if you have an idea on what you do to this patient, whether it be some type of capital osteotomy or a Reardon or an Austin, a first MTP arthrodesis, and B, a base osteotomy, some type of closing or opening base wedge, which would be C, a TMT1 arthrodesis, or a Keller, or some type of implant, why don't you text that letter to that text message, and let's see if this records anybody here. So A, B, C, D, or E, and then hit send, and let's see if we get any info back. I don't know if because we're not in the same room. Oh, okay. Well, that could be one person, or it could be all of you. Here we go. Okay, so we're tabulating. So we've got we've got, somebody took back their answer. That's very interesting. They were going to do a head osteotomy and then they decided against it. Okay, so we got about half and half. All right, got about half and half for some type of osteotomy of the capital fragment or an MTP arthrodesis. Okay, so what you got to do now is you've got to type clear to get your response away, or you won't be able to answer the next one. So if you type clear, you're going to get a little message like this, and then here's our. And you guys got to clear. So clear it and then answer again on what you would do on this 23-year-old active patient. I hope nobody would fuse her. So I know you people have not cleared your previous answer yet. Or maybe you do want to fuse her. So we've got 100, that may be a clearance issue, but we've got it. There we go. Okay. All right. Okay. So the first MPJ fusions are now clearing their screen and they're going away. And we've got head osteotomy and some people want to do a Lapidus. Okay. That's interesting. Nobody wants to do a Keller and an implant. Thank God, in a 23-year-old. I'm happy about that. Okay, so a little all over the board, which is not bad. And once again, no wrong answers. A couple more people using a Lapidus there, but once again, clear your messages if you could type clear. And now here's what I did. And once again, there's no right or wrong answer. The picture on the left is a biplanar first MTP fusion, and on the right, we did a type of a rotational first tarsometatarsal joint arthrodesis. Okay, and once again, nothing wrong with having done a head osteotomy on that younger patient or a basilar osteotomy. Absolutely, everybody's hands work a little differently. I figured some of you might have been looking at those plates on the left. This is a little off-label use, so I did want to mention it there. I do this procedure every now and then. There's an ulnar reconstruction plate from Zimmer Biomed. It's in the Alps hand system, and it's this plate right here, this little straight plate. And basically what we do is, or what I do is I take this plate, that's a 12-hole plate, that straight plate there, and they have some cutting pliers. And what you do is you cut those 2 holes off the end, and then you're left with a 10-hole plate. And when you slice it right down the middle, you make 2 biplanar plates. And these, you can see on that X-ray on the left, the most medial plate is the one that was cut on both sides, and then you can see the lateral plate on the very distal aspect was the actual end of the plate. These fuse really nicely because there's no interfragmentary compression and you get a little bit of micromotion. And of course, these are some of the plates that have led to one of the new industry systems for this type of fixation. So and that's that unit right there on the right. Okay, now I want to introduce you to 2 of my patients. This is Carol, and Carol's 54, and she's active. And here's Cynthia, and Cynthia's 50, and she's also active. So here comes John Quinones again asking, what would you do? Okay, and I want you to look at them for a second. And so this is my talk, essentially. I entitled it "To Fuse or Not to Fuse," a little Hamlet reference there. That is the question. And I have a subtitle of considerations for lowering our threshold for arthrodesis in Hallux valgus surgery. And of course, there's Hamlet holding that little bunion right there. So what would you do? So I do have no financial disclosures. My objectives are really, they're pretty simple. I just want people to think a little bit differently about bunions after this. The first ray is a clinical interest of mine, and I try to get better at this stuff every day because it's in front of us every day. I want to have you be able to evaluate HAV radiographs a little differently, maybe with a little bit more introspection. And my final objective is to provide my colleagues with a lower incidence of agita. I don't know if you know what agita is, but that is the Italian slang for heartburn. And none of us want heartburn after our surgery. We don't want to have to reach for the Pepto, wondering what we're going to do, waiting for that patient to come in when we see them on the schedule. Now, if you're a self-respecting Italian like myself, you don't touch Pepto-Bismol, you touch Brioche, which is basically Italian Pepto-Bismol in a pill. So that's one or the other. Both of them work pretty well. Once again, implants, we're not going to talk much about them because you really can't correct angular deformity like a bunion, anything other than really mild with an implant. If you are trying to fix a moderate or severe correction, either some type of biomaterial that you're using is going to fracture or fail, or your bone will if that implant is metal. You can't really fix any angular issue with an implant. These things basically have to be a straight column. Let me introduce you again to Carol. Carol's 54. And what I want to do is I want to show you Carol's lateral. And just take a look at, of course, just ignore everything else other than the first MPJ. But I want you to get a look at that lateral view and just take a moment to digest that. And then hopefully you've cleared your responses. If you don't, take a second to CLEAR and text that. And now I want to try this again, just simply based on Carol's AP and her lateral. What would you do? Let's see if we can get some answers here. Okay. Like I said, no wrong answers based on and it looks like everybody wants to do a head osteotomy, which is great. Okay, so I'm going to throw one more wrench into the mix. Why doesn't everybody clear the head osteotomy? Because we're going to get another poll here in just a second. And maybe somebody with a Lapidus. Okay, not a bad idea either. And I love TMT fusions. Okay, clear your answers. And let me show you, here's just a little clear reminder. Let me show you her sesamoid axial. This is a really essential view, in my opinion, if you're going to be doing any first ray surgery. You really, really need to be getting these images. If we've learned anything over the last several years with how HAV is treated, rotation is a massive factor. So they really do need to be obtained. I think it's getting to the point where it's going to be against the standard of care if you don't get these pictures. So that's my little 2 cents, but let's clear those. So now you've got three. Now you've got her AP, you've got her lateral, and you've got her sesamoid axial. What do you think now? Any, okay. I really appreciate everybody partaking. I figured this would be a little fun. So there were a couple people that were going to do a Lapidus with her, and I guess after the sesamoid axial, you've converted to. We have one fusion of the first MPJ. We got a Lapidus, okay. But the majority of you, and I'm gonna write this down. I'm gonna just I got a little piece of paper in front of me. 60%, about 60%. For the head, and about 30 and 15 for the Lapidus. Okay, all right. Clear your answers. Let's continue having a little fun here. Here's Cynthia. Here's my patient Cynthia. Take a close look at her AP. Okay, digest that a little bit. Now I'm going to give you her lateral. Okay, here's Cynthia's lateral. Once again, let's focus on that. First MPJ. I wish I could be with you today because I'd be using my iPad and my Apple Pen and or pencil and pointing to stuff, and I don't have a cursor right now, but that's COVID times for you. So so once again, clear those previous answers. And here is Cynthia's AP and lateral. And let's see what we get with her. I'll let everybody take a second to chime in there. A lot of head procedures. Okay. Okay. Well, clear your answers, if you will. And I'm going to throw the sesamoid axial wrench at you again. And I want you to take a look at that. Just gander at that for a second. It's going to get smaller on the next screen. And then if you've cleared your answers, we're going to do the same thing. Cynthia's 3 views. What do you think? We've got some fusions. First MPJ fusion, about 33%, and a lapidus based on her angulation, very, very appropriate. It's about 80-20 or so. A few of you guys and gals want to do a head osteotomy. Okay, we're right around there. All right, well, let's get into the meat. Let's get into the meat of this. We got about 10%, about 30%, and about 60% with a lapidus for Cynthia. Okay, let's just think back about the complications of hallux valgus surgery, shall we? I'm not going to read this list to you, but we all know kind of the list. A lot of these we know, in our own mind. And I did go through a number of papers. I just pulled some up to just make sure that I wasn't missing anything off the main list. And these are all the main guys. And there's one interesting one at the bottom I wanted to show you. Painful stiffness. So painful stiffness is not articular cartilage stiffness. This is that relates to arthrofibrosis. So there is tightness of the tissue based on what we did to our joint, maybe what the patient has biologically, how they heal. Do they make hypertrophic tissue? If you took care of everything that you could have taken care of, they were going to get stiff anyway. But the joint is basically okay. This is in the tissue. But I want to add one more. Metatarsophalangeal joint arthritis is a complication of hallux valgus surgery. And like I said, I think Dr. Sprunger had just right at the end there, I thought it, once again, it was so perfect that he ended with that. He did such a very nice job of reconstructing them. But those were people that had an Austen-Akin, and something was unrecognized, because we want our surgery to be the last surgery, of course. Now, nothing in life is 100%. I tell my patients that, but I see this a lot, and I'm sure you do. And maybe we don't see our own bunions getting arthritic because a lot of times they're not coming back in our door. They're going to the doc down the street. So you're batting 1,000, but you don't know because they're not coming back to see you. I can't be the only guy that sees this happen. These are just some pictures off the internet. Look at that basilar osteotomy on the left. That joint is going down. Nice correction. That middle one, you've got a malunion, and that person was just kind of asleep at the wheel when they threw that screw. But look at that joint degenerating. Here's another one, a little more subtle, but a fairly nice Austen. But look at that joint squaring off. And here's a couple more. Here's a Reverden on the left with an Akin. Look at that joint going down. This is on the right, a pretty nice lapidus with a kind of the home run screw into the cuneiform, which may or may not have to be removed when the patient gets walking. If those break, sometimes they're not a huge issue. But once again, close to an IM of 0, I'd say. Beautiful correction. And here goes the joint looking bad. This is a orthopedic specialist in my area. And yeah, so that Aiken screw is not supposed to be there. And this person, or the non-union of the lapidus, but this is the All-American that this person does. This person knocks out these lapidus Austin Aikens, and I don't know how the hell it happens, but they still have a bunion. And you know, that's just a horrible, there's not much to say about that surgery right there. And I could keep you here an hour showing you those over and over again. Sometimes the changes are a little more subtle. Here's just a canned photo off the internet, a pre and a post, and you could just see, there's still angular force on that bunion, and that joint's going down. And I would ask you to consider the long-term outcomes of all the bunions that I just showed you. Those are looking like they're going to potentially have to have some type of procedure done on them. We're maluniting some of our bunions. This is a malunion, and it's our malunion when we don't get our complete correction, when we don't rotate our first metatarsal and put our sesamoids in the right position. It may look good for a little while, but the forces across this joint are so finicky. We should all know this. I wanted to kind of put this slide up because I know some people that just do Austins. And for those people that really don't do anything else, and this is not junk science, this isn't my numbers. If you only do Austins, what percentage of your surgeries are you creating a malunion? Now, by malunion, I mean even a recurrence, which is, of course, something being malunited and returning. And if you didn't know, X is 75 to 80%. And it's a shocking number, but it's actually in the science, because this is the landmark paper from Kim that all of the new techniques of Hallux valgus surgery are based on. This was just a fantastic paper. And this is the metatarsal rotation. And in the upper left, that's not a bunion. And in the upper right, that is a rare condition of no pronation of the metatarsal, but subluxation of the sesamoid. So that is a pure transverse plane translocation of the first metatarsal. You can see on the bottom two, number 3 is first metatarsal rotation with what's called pseudo-subluxation. So in other words, you're looking at that AP view, those sesamoids are displaced into the inner space, and you see an increased tibial sesamoid position, but they are right where they should be, below the first metatarsal head. And then number 4 is rotation of the first metatarsal with subluxation. And the number 2, this is the only time that you really can do an Austin, because an Austin really, and many other procedures, can only get you a transverse plane correction. And number 2 happens in about 20%. The other 80% of bunions really involve, according to Kim, some rotation of the first metatarsal. And if no one knows Hero, he's in our profession, he's out in Texas, he's a genius. And another paper, just a landmark paper about what is involved with, what factors are involved with early loss of HAV and HAV correction. And this is right from the paper. After adjusting for covariates, the only factor associated was postoperative tibial sesamoid position. And if you're over number 4, you're going to get your bunion back half the time. And if you're over TSP5, you're going to get it back 60% of the time, which they're really astounding numbers. And so this has led to a lot of these new ways to fix bunions. And I wanted to list many of them. I'm not sponsored by any of these guys, once again, but I wanted to be complete, and they're in no particular order from top to bottom. But they all do a really beautiful job of helping us, through research, identify a major issue with HAV surgery, and that is this rotational component of the first metatarsal, and helping us improve our outcomes. And once again, I know there's some billing gurus out there. My bunion evaluation is an AP, it's a medial oblique, it's a lateral, and then it's a sesamoid axial. Absolutely, absolutely. These 4 views. And what I'm doing is I'm billing a 73620, and I'm also billing a 73660. Now that's a 2-view foot and a 2-view toe. And I used to have no problem with this, but lately, over the last 6 to 8 months, my biller, we were getting some rejections. And so now in my notes, I literally say this when I'm transcribing, when I'm dictating. 2-view foot and 2-view toes were medically necessary to fully evaluate this person's pathology about the first MPJ, and it looks like I've had no issues. But if you want to see, this is the little sponge that I use. They're about $150 on Amazon. And this is so important to have. You cannot have a bunion practice without one of these. You really can't now. And this was an interesting patient. Just recently, you could see her billing dates were, or I would say the collection dates were on the 14th of October of last year. So Barbara, she basically had a 3-view foot on one side, and she had a 2-view foot and a 2-view toes on the other. I can't remember what one it was, but let's just say her left foot was the 2 and 2, and her right foot was the 1. And so those were what paid. That's what paid. And then, of course, her secondary AARP, they kicked in a little bit more there. And so, we all have to keep our lights on, of course. And this is just, it's not for the money, of course, but we have to do ethical medicine. But of course, we have our staff to pay, and we have to live. And, here's what we got. That was her total for her right foot. This is Medicare with a supplemental. Here's what we got total for her 2-view foot, 2-view toes. And I see this all the time. And once again, you're putting, if you want to do a little practice management, just blurb for a second, this is good medicine, and you're putting money in your pocket. It's the same with Medicare Blue. And it's the same with Blue Cross. It just goes up a little bit. So it's good medicine. Here's a paper, Jorge Filippi out of Chile. We should all know his name. He's a very, very renowned foot and ankle orthopedist. And this was a very recent in foot and ankle clinics, complications after med osteotomies. And he named primarily just a few, but one of them was malunion. And once again, a malunion is an improperly aligned and healed osteotomy. Well, malunion, we make malunions when we don't reduce our bunions correctly. That's a malunion. And this was one of the pictures from this article in clinics. And I'm going to blow this up a little bit. I want you to look at that. And this is what we're talking about. This is what happened to Tad's 2 patients. They had some unrecognized issues on their x-ray, and this is what was done. This is an Austin and an Aiken. If you look at that bottom picture, ladies and gentlemen, that's not fixed. That is not fixed. We did this person no justice. It's not fixed. Here's the CT. If you think that's fixed, it's not. There's a screw. There's a tibial sesamoid position. And here's a bunion that's coming back and becoming a crummy joint and an unhappy patient. And I would venture to say that when we pull that list up, if we cross out a couple of them, the ones that we do more so with our dissection, I'd say that a ton of these we do ourselves with our osteotomy. And that's a lot of complications to have, when we're not getting it right. And so, I think about bunions a lot. This happens at least a few times a day. My staff will catch me just pontificating over a bunion. Sometimes I really don't know what to do. And so I just kind of sit there and wonder, but a little brevity there. These are absolutely going to go on to a joint destructive procedure. 100%. These joints are going bad. And this wasn't the last surgery for this patient. And I guarantee you, when this patient signed this consent, that doctor said, we're going to fix your bunion and you're going to be out of here. And here it is. coming back. And of course, you know, that both of these APs, the apex of the deformity was not corrected. That's an improper bunion, in my opinion, to try to address with a capital osteotomy. You really need to go after the cora, and so many doctors have showed us that. And the cora of some of these deformities is at the first tarsometatarsal joint, and that was not addressed here. So, you know, once again, a clinical interest of mine, I do a lot of second opinion work on some of these ones that have not gone so well. And I always try to tell my patient, look, nobody bats 1,000. I really don't ever, I don't think I ever throw anybody under the bus. There's some people that I really don't like in my profession, not necessarily in Michigan, but I'll leave that for another discussion over drinks later. But I don't think I've ever tossed anybody under, and I just tell them, look, this is what you've got, and this is what we have to deal with. But a lot of my thinking over the last few years has been trying to evaluate these bunions more carefully and trying to think about who this is going to happen to more, because I know that I can't fix it perfectly. Maybe I can't get that TSP exactly to 1 or exactly to 0. Stuff happens in surgery. So which one of these ones am I leaving just a little malunited? And are there any pre-predictors, so to speak, that are I can pass on and I can do the osteotomy or a more proximal fusion, or do I need to consider something else? Do I need to consider that, hey, this joint may go on to have something else happen to it? And once again, a malunited osteotomy of my own doing. Am I gonna make this bad? Because when you look at the algorithm for first MTP surgery and bunions, look at the first yes and no. If you have arthritis, you're supposed to do a fusion. But here's what I think about. What about pre-arthritis? What can we predict if somebody's going to have a problem, and if we don't fix it exactly right? Are they going to be back in our office in a year going, what happened to my joint? I have no more bunion, and now my joint won't move. And now it hurts more than when I had the bunion, doctor. And we don't want to hear that. So we all want excellence in our results, and we want to be truly excellent. And I've learned to look at some real subtle radiographic changes. And these are new concepts that I'm going to throw out. Please use at your own discretion. This is one man's opinion. You're not going to find this in McGlamry. But I just want you to, I've really done a lot of thinking about this, and I want to let everybody in on some of the stuff that I've thought about. So here's some of the things that I think about when I'm evaluating a first MTP. And I really pay a lot of attention to subchondral cysts, and I pay a lot of, and especially where they are, and we're going to go into that in a second. I really pay attention to the sesamoids, and that those are two very important little bones when it comes to the first MTP. And I think many times they're ignored. We're going to talk about osteolysis of the metatarsal head, and we're going to talk about narrowing of the joint space, peripheral narrowing of the joint space. And then this is really my nomenclature. There's something that I call the grind sign, and we're going to talk about this. The grind sign is also associated with a subcomponent, and I do something called the corrected range of motion test, and I'm going to actually show you that. And this is really, really important for any bunion that's being fixed. And so let's just go over these 5 issues really quick. You know, subchondral cysts are a very important window into what's going on in a metatarsal head, in an ankle joint, in a knee, any joint really that's an axially loaded joint. And you know, this is the actual definition. It's a cartilage defect because of stress peaks in the subchondral bone. And what happens is this bone can fracture, and a lot of times some joint fluid is sneaking past the subchondral plate into the intra-substance of the bone. And what the bone is doing is it's walling itself off because it does not want any of this fluid inside there. Here's Carol and Cynthia again. I'm going to keep coming back to these two patients, but look real close. I want you to see these little signs here. Now, they're mild, but to me, this is everything. This is the start of, for all of you guys, and maybe some of you are doing this and I commend you, but if you're not, I want to bring you on the bandwagon with me. This is the start of a new way to look a little closer at these, and digital x-ray helps so much with these, because before the only thing we could do was put a magnifying glass up to our plain film, and now we can blow these up. We can there's at least on my x-ray system, and I know yours, there's a bone, I forget what it's called, but it just allows you to get a finer look at the bone, and you can dial it in and really look at these closely. Let me go back to that one more time. Once again, I did want to mention where these are. I do find that these are typically centrally and at the periphery. And we're going to talk about narrowing at the periphery in a second, but Cynthia's got one right in the center there. And sometimes, honestly, you might overlook these, but we're going to see in a little while why these are so important, okay? So I'm not going to belabor cysts, but there they are, all right? And that's fluid getting underneath the cortical surface of the bone. Here's our little sesamoids. Here's again, this is Carol. Carol's always on the left and Cynthia's always on the right. And what I notice is, look at Carol's tibial sesamoid. You see that thing digging right into the bottom of the bone? You'll see a loss of the joint surface. And with that, you'll see sesamoids going from a beautiful round sesamoid to a flattened sesamoid with, if you look at Cynthia, do you see those spurs? Once again, I forgot to put a little circle there. I wish I had my little Apple pen, but look at the lateral side of Cynthia's tibial sesamoid. Look at that growth coming off there. That sesamoid's being beaten up. And the reason why is because they're pulled laterally because of the motion of the hallux. And now they're getting basically driven on by, Z said I can use the cursor. I think I'd have to almost like get out of my screen here, let me do this. Let me pop it. Okay. Right here and right there. Let me get back to the big screen. But if I have to do that again, I'll go by. But you know, these guys are being smashed on by that crista, and at the same time, the crista is eroding, and we're giving our hallux valgus a chance to worsen. And so if you don't remember what good sesamoids look like, that's it. Look at the space between those sesamoids. That is a joint. That is the sesamoid plantar first metatarsal articulation. And here's my lady in the beginning with that ulnar recon plate that I fused. And here's her sesamoids, Virginia. She's a sweet lady. She's actually doing fantastic with this. But look at those sesamoids. That's what happens to sesamoids preoperatively. So that guy on the right goes with that guy all the way over on the left. And those guys were just being smashed to bits. And prior to that fusion being put down, I'm trephine reaming around that metatarsal head, or I'm planing with a sagittal saw the plantar aspect of that first metatarsal and taking a few millimeters off the plantar aspect. You don't need it anymore when you got a fusion. You got to make sure that you round the edges, of course, with some type of rasp. That's why the trephine reamers do so well. They round the whole metatarsal head and you just fit them right over the head. And I've gotten so good with that instrument, I don't need a wire anymore to put it over. You just kind of centralize it right over the head. Any of the guys who have the commercial sets or your hospital can find a trephine reamer, and they work great. Here's a little upcoming bunion surgery. This lady, she's a 50-year-old active female patient. She's got HAV. It's clinically pretty large, and this is a wife of a good friend of mine. He's actually in the Chamber of Commerce. One of my Chamber of Commerce is with me, and I'm gonna operate on her. So I really wanted to be sure about this because I was considering doing a surgery on her, and I wanted to make sure. And look at that bottom right photo with those smashed sesamoids. And that's what I see. Now, some of you may look at that top view and see an Austin or see a Lapidus. But and once again, there's no wrong answers, but I'm trying to bring you down this path with me that the way I look at things, I'm looking at that a little differently. And it's because of that bottom right x-ray. And so what I did on her was, because I wanted to be sure, here's those again close up, I got a CT scan on her. And I love Basha Diagnostics and Reza Sesgari, who's lectured to us before, reads the majority of my MRIs. And he texts me with all these pictures. I love it. But look at these images that he sent me back. Look at the lower left. Look at the spur on her sesamoid. Look at the cysts in her metatarsal head. If that's not fluid leaking inside that bone, and that bone responding because of pressure and insufficiency of the subchondral bone, and you think that realigning that joint into a more appropriate way so that it's actually going to take greater pressure is going to do this patient any favors, you really need to think again. And once again, this is, I guarantee you, this is what happened to Dr. Sprunger's patients. They had a joint like this, and they were given an Austin-Ankle, and everything got realigned. The hallux, which was articulating laterally, was now put in a position where it needed the entire head to function. And it needed good sesamoids, and it needed good subchondral bone. And this is probably something like what it got. And it has no recourse but to break down and require a chilectomy. And that fails because there's no cartilage. And then, thank God, Dr. Sprunger is in Troy to help these people out and fix them up, because that shouldn't have been, in my opinion, an Austin-Ankle in the first place. And I didn't see those patients' x-rays, but I think we're all going to get a little better look. And maybe we do something a little bit differently based on what we find out. There's those cysts. That just is not healthy bone. Let's talk again about osteolysis. You know, I look at some of these x-rays I see, and I for years I've wondered what's going on there in that corner. You know, I understand that the sesamoid's not under there, and you're only looking at one segment of bone. You're not looking at double dense bone, but look at the other parts of some of the other bones. They don't look like that. Look at the soap bubbly appearance of that, and you know, it just looks odd. Look at the whole medial aspect of that head. You see some of these in these bunions, and what this is this really is a insufficiency of the subchondral bone. This is, maybe it's not a fracture. This is kind of the end extent of it. But here, let me show you. This is a fairly normal metatarsal head. This is that patient right here. So this is Cynthia. So let's just say, based on the angle, this most likely would need a first TMT arthrodesis. You know, if you can squeeze it. Now, I'm not. There are people that are doing MIS on these, and this is not the lecture for that. I'm not probably going to be an adopter of MIS, but that's not to say that it doesn't have its place. But you know, I drew this line axially right down the pipe. And look what happens when you rotate that metatarsal into a proper position. See what you're doing. There's not a whole lot of stuff to shave off that metatarsal. So, I mean, if you take too much off, we're getting a PSI issue. Now you're decreasing the width of the metatarsal head. You're increasing pressure. But let's just say you don't touch that metatarsal head at all, and you get all your correction from that basilar osteotomy or first TMT fusion. Look what you're putting underneath the first joint to have to function now. And it would be my argument that you're putting bone that's really not the strongest bone to begin with. And you're leaving this joint potentially to its own vices. And, you know, I wish I had a little bit better CGI movement on that. I was going to call Spielberg in, but now actually I think I'm just going to use Dr. Bernanke and his green screen. I was super impressed. So he's going to, I have a private lecture coming up with him later on. Tom, I hope you're ready for our talk. So here's number 4. This is slight narrowing of the joint space at the periphery. This is back to our patient Carol. And I want you to notice just the very edge, the lateral edge of that first MPJ. I always pay special attention. Let's look at this again in a little bit of a bigger close-up position. It doesn't look like much, but you can see the narrowing. And what that's showing you is that you're losing cartilage over at that lateral aspect because your hallux has been articulating for so long in that corner that you're starting to get articular wear. And interestingly, this typically does happen laterally. We're not resecting that bone. And if we are doing some medial eminence resection, we're decreasing the surface area of our first MPJ. And we're actually going to increase pressure along the whole metatarsal. And, even soft tissue contracture from the way a patient heals, or your kind of poor handling of tissue, or you get a little hemarthrosis of that joint. All of these are going to make this a little stiffer. And just interestingly, look at the cystic formation. It's just so slight, but you can see that subtle change. This is the corrected range of motion test. This is essential. When you have a bunion, you need to take it through a range of motion in its position. But watch what I'm going to do here. I'm correcting that great toe, and I'm actually loading. I'm pushing. I'm going to do this in another segment where I really push it over, and I'm loading the first metatarsal. You're going to feel crepitus when you load. I'm going to play that one more time. You're going to feel crepitus when you load that first MPJ right over the joint line. When you put your finger over the joint, just like that, you're going to feel a crackling. And what are we doing with our osteotomy? That's what we're doing. This is the new position we're putting our bunion into. And if you've got crepitus, when you corrected range of motion, this great toe joint, that's giving you a little window into what's going on underneath there. And this, combined with some radiologic findings, have to be giving you a clue as to, hey, maybe this joint has got something else going on. Here's my little grind sign, I call it. So Z and I had a little debate about the elevatus, and I do believe that there is elevatus. But here's one of the things that I look at when it comes to bunions. When you have an elevated first metatarsal and you've got kind of a combined hallux rigidus, or I would say functional hallux limitus with HAV, your proximal phalanx is not clearing the metatarsal head very often when you're in motion. And what it's doing is you're getting a digging of that medial base of the proximal phalanx into that articular cartilage. And once again, that articular cartilage, when you do an osteotomy, that's being rotated into the position where you need that to be as good as it can be, because that's your new metatarsal head. And I call this a potential grind sign. And when I see that, I'm thinking about what's going to happen. And that grinding, wearing down is also causing some of this penetration of the cortical surface of your first metatarsal, and potentially allowing for some of this entrance of joint fluid into the metatarsal with these issues that we're looking at. Look at that very distal aspect of that joint on CT. You can see how close that is, what damage it's causing to that articular surface. Look at the cyst right below that medial base of the proximal phalanx. And this is something that's got to be discussed. And here's what you can do. The least thing you can do is discuss the possibility of your patient. I'm not saying you can't do an Austin, and I'm not saying that every time you have to do something like a joint destructive procedure, but make sure there's options at the time of surgery. And here's what I do. I consent them for both procedures. This is Carol. This is the lady we've been seeing on the left. And I had a suspicion about her joint. And so I got her in there and I said, Carol, her sesamoid axial was not very rotated. She did not have a massive IM. She was a very pretty decent candidate for a potential Austin bunionectomy. And I said, look, I'm either going to move your bone over, or if the cartilage is bad, you're going to come out with a fusion. And she knew. And look at her writing on the right hand consent. I always make them write in their words, left foot bunion surgery with a possible fusion. And she even wrote TBD. And that's perfect. That's what you want. That to me is informed consent. My joint's either going to be moving or it's not going to be. And of course, I take a ton of pictures in surgery, and we're going to show her why we did the one over the other. Here's my picture consent. She's signing fusion or shifting the bone over and fixing it. And, you know, I don't do a ton of head procedures because I really do a lot of Lapidus and I do a lot of fusions. But once again, this was her. She had that type 2 metatarsal, very little rotation, purely transverse. You do an Austin bunionectomy and you shift that over, there is no rotation. You're going to have a very low risk for ill-placed tibial sesamoid, and you're going to lower your risk for recurrence. And then I look and I see that sesamoid, and I know that the mechanics of that joint are not good. I know it now. After all the time I've been doing these, I know it. And I want you to look at that on your sesamoid axial combined with some of these other findings. And I want you to consider that this joint may not be the joint that when we get in there and the only thing they're consented for is an Austin, and you get in there and that joint looks like shit, and you say, oh no. Because if they're not consented, you theoretically probably now have to do an Austin. I'll never forget in my first residency at Roger Williams Medical Center, I opened a first MPJ for an Austin with my residency director, Pete Sardella, who's like we talk every couple months still. He's a genius and he's a huge mentor of mine. And I'll tell you, that lady, I know that he was upset that he didn't evaluate that joint very well, because we got in there and her cartilage was gone and she was consented for an Austin. And you know, 3 minutes of somebody looking at a joint, that time passes so slowly when you see somebody thinking about that they made the wrong decision. And Pete Sardella, I think, did the most something with the most integrity that I've ever seen. We didn't have cell phones back then a whole lot. No cameras, of course, like that. But we all had our beautiful little Nikon Coolpix cameras. And he took a couple shots. He scrubbed out. He went out to the husband and he showed him those pictures. And I was still there. I was scrubbed and I was kind of nervous. And he came back in and those 2 7 screws got put away. And he grabbed the 3 5s and we did a first MTP arthrodesis on that patient, and she had a wonderful outcome. And he did it the right way. He went out. He clearly wasn't going to wake her up, but he made the right choice. And now I don't want you to have to do that. I want you to be ready, to be prepared in the OR when this comes up. I want you to be ready. Nobody should have to scrub out. Look, again, no rotation. This is a beautiful Austin. If it wasn't for these little concerns on her that I want you to pick up on. Now let's look at that. This is Carol, and once again, let me refer back to my thing here about 60%. And once again, I'm not picking on anybody. You can see where this is going, I'm sure. 60% of the answers were a head procedure, 30% were, I think, a Lapidus, and 15% maybe were a first MPJ fusion. This is that head. I just want you to mull on that for a second, because I think some of you now are realizing that what we talked about and what you're looking at, that is not an Austin-worthy first metatarsal. And if you opened this and saw that, and you knew that you had to move that over and make that thing work, you'd be a little skittish about how this was going to turn out. Let me blow it up for you. Look at the cartilage. Look at the anterior facing cartilage. Just horrible. This is the phalanx base. I don't know if you can see that, but that's subchondral bone right there. This is interesting. You know, now you can look and see that is the grind sign. Look at what the phalangeal base has been doing to that metatarsal head. Let me go back. Look at where that's been digging. I mean, that's impressive. That's subchondral bone right there, folks. There's that base that's been digging into that and the increased pressure. That's it. It's all about PSI. It really is. This is nothing more than simple physics. You know what else? The interesting thing about this is this goes all the way under the bone. This tracks directly planarly. And let me remind you, here's her lateral and here's her sesamoid axial. And that thing has been being dug by that tibial sesamoid, driving into that bone. If you think that an Austin is going to function with that sesamoid in that groove for long term, once again, that's doing that right there. That's not a good joint. Look how thin that upper third of the cartilage is. Really beat down. PSI. I told John, he was in the lecture, these cadavers, we actually got 2 papers out of this, but John did just a beautiful study. I read this every now and then just to remember. We were in Ann Arbor on this Instron machine doing this, but John's study was fantastic, and he really showed what we all know. But I think he really was one of the first guys to prove it. He slipped pressure sensitive film into that ankle, and he showed that as that fibula displaces in a Weber B, clearly, I mean, this part, as it moves, you lower your contact area. But what's the subsequent to that? Well, the pressure goes up, right? This is PSI, folks. The first ray is a column. I don't understand all this math stuff, but this is for people smarter than me, but this is about critical load. This is about when columns bend and there's pressure at a point. Doesn't that look like something that we deal with all the time? That's HAV. What's the difference between this and this? My contention is nothing. So why do we treat the one on the left with such reverence and the one on the right, we just put it wherever kind of needs to be? This is all about increased pressure from decreased contact area. And we know that if we leave that fibula like that, it doesn't look all that bad, but that person's going to have a bum ankle in no time. And that's what's happening to that first MP right there. Look, now you're starting to get it, right? You're starting to see. Look at the cyst. Look at the subchondral insufficiency that we talked about. This might be an Austin consideration for you before this. I hope you'd consider consenting this patient for both, just in case. Here's another one I picked up off the internet. For any of you, by the way, if you need some pictures of bunions, you can buy this. I didn't get to see what the cost was, but look again. Look at these 2 metatarsal heads. You're starting to see it, right? Look at that medial bone. Look at the lateral peripheral joint loss. Look at the grind sign, especially on the left. Look at the cyst associated with that medial base of the proximal phalanx, what that's been doing. Now you're seeing it. Now you're looking at them a little differently. That's a normally shaped head, pretty much, especially on the right. There's a little medial eminence on the left, but what can you do with this? You're either going to stake it after you do an Austin, or you're going to make that medial portion right there on the right, you're going to make that function. You're going to make that a part of your joint. And I tell you, looking at that preoperatively, I know that is going to come back to you or somebody else in a little while, and it's not going to be doing well. You're starting to see. You're starting to get it. Here's Carol. She had a first MTP arthrodesis. I figured you knew it was going that way, but she's doing great. She's doing great. Okay, and I picked it. I picked it from the get-go. And this is what I want everybody to start thinking about. I would have easily done an Austin on her if my premonitions had proved incorrectly. And I got in there and everything looked just beautiful. I'm not going to fuse a joint where you don't need to fuse it. But I would have done her a disservice, as you saw in those photographs, if I did an osteotomy on her. Here's Cynthia. Now we're looking at this x-ray a little differently, right? Look at the grind sign. Look at the cyst underneath the medial base of the phalanx. Look at the subchondral insufficiency medially. Look at the sesamoid irregularity. And that's what she looks like. That's a bad joint, folks. You're starting to see it again. Look how much articular cartilage is left. And what's left isn't all that decent. I mean, that's it opens your eyes when you see it. Look at the base of the phalanx just eroding from that pressure. Interestingly, that's that subchondral insufficiency right there. That bone hasn't had articulation in a while. She's been functioning laterally. The cartilage is just going away. Cartilage, we all know this. Cartilage needs pressure. And if you don't use it, you know, it's not going to be there. Mind you, this is before honestly, these pictures are right after opening. I haven't touched the front of that bone with any instruments. That's as is. See that cyst? That's right there. This was a fusion in a couple people. About 60% of people wanted to do a Lapidus on this. Once again, I hope I'm opening your eyes a little bit. If you did a Lapidus on this and lined this up, look at that joint. That's not going to last you. Now, the interesting thing about this patient, a little side note, is that she had the most severe allergies to metal as I've ever seen in my life. This makes this case very interesting. She had horrible nickel allergies, and I thought about what I would do for her. And, you know, my main thoughts were, and I had these discussions with her and her husband, if I need to fuse this joint, and because I knew it was going to look like that. I just knew it. And I said, I'm either going to put metal under you that we are going to have to take out at a later date, or I can fuse you with something that I can totally remove. And she was all for that. Why a second surgery when you can do something that you know, can be removed pretty easily? And so here's Cynthia, and here's what I did. And I'll tell you, that's $18 worth of hardware right there. This is a pretty inexpensive fusion. And this isn't something I came up with. This is, you know, Alan Banks is no scrub. This is Tucker. Immediate weight bearing following first MPJ joint fusion with K-rod fixation. And that's where I learned it way back when. Now, of course, they bury two of their wires, and they throw a long wire, of course, across everything for a third point, and that's the one they pull. But I left all three of Cynthia's out because of her allergy, and because I knew that her horrible nickel allergy was, you know, there's nickel in stainless steel. This is part nickel alloy, so I knew that this was going to be bad. So we're going to fuse that joint, and no problem. I pull her pins out, and all is right with the world. And of course, if you just want to see the results of this paper really quick, you know, they did 22 feet, 20 patients. They had 3 issues. One delayed union was revisional, and then one non-union had spastic diplegia. And I think you can probably think about that joint just moving constantly a little bit. This person with a neurologic condition that can't help it. So really, all these went on to healing without any issue in this paper. And so 3 out of 22 is really not bad for 3K wires. But unfortunately, I did not have the best result. I think I did a pretty good job there on the left. If you can see on the right, we've got good opposition of our fusion. And this is, of course, this isn't, you get a little compression with these, but this is mainly very stable splintage. Look at the edema. By 1 week, she had a massive exanthem rash on her chest. She was popping Benadryl. I was already having to deal with this. The little bit of nickel in this wire was starting to be an issue. This is a tree right here. Look at this. This is 4 weeks. Look at the bone dissoluting from. This is an AVN, folks. This is metal reaction. Look on the right. Look at the fractured piece of cortex coming off. The edema. I was, needless to say, she loves me, thank God.